Welcome, everyone. We'll get started here this morning. First of all, before we start, I want to recognize we have a couple of celebrities in the room. Senator Dockstader, welcome. Welcome to the other half of the county. Senator Dockstader lives in the north part of this county. We let him down here once in a while. Actually, I
Is this
generally,
the true part of the county?
I won't say that. I have to be careful what I say here. I usually run into Senator Dockstader downtown at the Maverick station. We cross paths. He's going one way and I'm going another, and we cross and class cups of Coke. Welcome, Senator Dockstader. Next to Senator Dockstader, we got one of our county commissioners, Commissioner Conley. Welcome. Good to see a smiley face back there. Everybody in the room is a celebrity, frankly, except for Representative Larson, but we'll welcome him anyway. Okay. I've got this whole sheet of paper that we normally are told to read about how to behave in committee meetings. You all know how to behave in committee meetings. Behave. We're all kind to each other. We don't call each other names. And we're generally just nice to each other, ask appropriate questions. All the conversation goes through the chairs, that being Representative Larson and myself. And Representative Larson has told me that I'm chairing today because something about he chaired last time, but I don't remember. Y'all remember? Shake your heads no, even if you remember. Okay. All right, this morning, we got a pretty good agenda here this morning. It's not super full, but the conversation will go a little longer than what shows on your agenda sheet. So hopefully we have a good, productive conversation. We got some folks here this morning representing the local school system, which is the other celebrity in the room. Where is she? Oh, she's hiding back here. This is our administrator, our local administrator from Lincoln County School District 1, who coincidentally was named the Administrator of the Year. Is that the correct title? Superintendent of the Year. See, I got that wrong, but this is Teresa Chalk, and she'll be one of the first ones talking to us this morning. And I believe that Jen's coming up with you. Is that correct? So without further ado, we're going to start off this morning talking about K to 12. Oh, we better do a roll call to see who's here. Go ahead.
Good morning, Mr. Chairman. This is roll call for the Mental Health and Vulnerable Adult Task Force for June 13th. Senator Barlow.
Present. Good morning.
Is he online? Yeah, he's behind my head, so you have to tell me if he's here.
Senator Nethercott. Here. Speaker Summers.
Excused.
Representative Zwanitzer.
Here.
Director Johansson.
Here.
Director Schmidt. Here. Director Shannon.
Here.
Mr. Brown.
Here.
Mr. Birmingham. I don't see him online, Mr. Chairman, just yet.
Excused for now.
Co-Chairman Larson.
Here.
Chairman Baldwin.
Here.
You have a quorum, Mr. Chairman.
Thank you very much. Go ahead, Representative Chairman.
So to our PBS guy back there, I can barely, when our folks who are online acknowledge their presence, I could barely hear them. So just, if you would just kind of tweak that as we start hearing that, where we could, was I the only one that could faintly hear him? Okay. Mr. Chairman, could I have a personal liberty?
Oh, absolutely.
So just committee, I'll just, this Kimmer area kind of has some unique perspective for my family. I had some of my great grandparents were part of the early migration of the Church of Jesus Christ of Latter-day Saints to the Salt Lake Valley. And I had on my mother's side, a grandfather, Maxfield, who he and his wife were in part of a wagon company, and she gave birth to a child here on the Hams Fork in the late 1800s. And that was a very difficult birth, and she was not recovering well. They held up the wagon train for a couple of days, and then the wagon master said, you know, I'm sorry, it looks like your wife is going to die, but we need to move on. So there were some families that were living in the Kimmer area that knew of their camp, and he brought his wife and this newborn infant to these folks and said, you know, here's my wife and this newborn child. I'm going on with the wagon train and not expecting her to live. Well, she recovered following wagon train, but just a short number of days followed, and she got on with that wagon train and beat him to the Salt Lake Valley and was waiting for him. and said, you were going to leave me there to die on the Hems Fork. And I thought, man, those folks had grit, but that woman is a hero in my mind, what they done. And I think of the generosity of the folks that lived in that area that took care of her and that baby. And I would just tell the task force that that legacy, that generosity, I think still exists in Kimmer today. I think these are some of the greatest people in the state of Wyoming here in Lincoln County. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. That was a great story, and we appreciate those kind words. Just a few words about Kimmer. Y'all just missed the groundbreaking of the new Natrium TerraPower nuclear plant just south of town. That was on Monday. PBS was here. PBS is going to have a new station just based in Kimmer, I believe. Bill Gates was here for that groundbreaking. He played a little poker in town, is what I hear. I missed out on the game. I didn't have enough money to buy in. But Kimmer, there's a lot going on in Kimmer, as you all well aware. The new nuclear power plants coming in, of which Senator Dockstader is a big part. We talk about coal mining a lot when we're up in Cheyenne, and that's what founded. That's where Kimmer came from, was coal mining and the railroad. Matter of fact, if you go, I don't know, Jen can probably correct me if I'm wrong. It's about 2 miles, maybe 1.5 miles straight east of here, up partway up the hill. It's an old mine. There's no markers or anything on it now, but it was at the time, it was the largest coal mine disaster in the state of Wyoming. And I'd give you a date. I'm going to say 43, something like that, 1943. But 99 coal miners were killed in the Frontier Mine #1 disaster just up the hill. As I say, it's just not all that far from where you're sitting right now. And if you go along this ridge, there's coal mines all up and down the ridge, including several ghost towns. The town of Cumberland, which was a fairly significant coal mine, and there are several coal mines along the hill here. And coal is still going well here, and we're going to keep it going, hopefully. But sometimes we overlook the coal mines here, and it's a big deal. It's a real big deal.
Mr. Chairman,
New stuff coming in. Go ahead.
Isn't there a spiritual side to Kimmer as well?
Sure.
During the Prohibition, it was a
Well,
great distillery, and
we're careful what we talk about. Yes, the best distillery in the state. With that in mind, now you've got all the history. Welcome to Kimmer, and enjoy your time. So let's start off talking about K-12. Come on up. We've got 2 folks here from our local school district, and I'll let you introduce yourselves to the committee. As I've told you, don't be nervous. Jen was a little nervous this morning, but so don't be nervous. We're nice. The guys behind my head, I won't look at it, but they're pretty nice too. So go ahead and introduce yourself and tell us what's on your mind. Just push for the green button.
All right.
There.
I'm Teresa Chalk. I'm the superintendent, Lincoln County School District #1. Chairman Baldwin, Co-Chairman Larson, and committee, thank you for having us here.
I'm Jennifer Benson. I'm the K-6 school counselor in Canyon Elementary.
I thought we would just start off by reading a couple short statements from 2 of one counselor and 1 social worker that couldn't be here regarding mental health needs of our students. I'll start off with a statement from Cynthia Platt, and then Ms. Benson will speak, and then I'll talk about things we're trying to do to mitigate it, working with Wyoming Department of Ed and things like that. So over the last 3 or 4 years, we've seen a rise in mental health needs. I have noticed that in 1, we have increased hospitalizations, increased number of kids whose mental health concerns affect the normal schedule, over on attendance, have to go online so that they can complete school at irregular times, and asynchronous type settings, difficulty fulfilling typical expectations in class with peers and staff, and we've had an increased number of dropouts. In addition, the numbers have grown with the number of suicides in our community and suicidal ideation among our students. We also have noted that students are requesting more mental health support, although many students complain about the social emotional learning curriculum, which is SEL. For example, after SEL lessons, it is common to have students come in to let me know in private how much they need that information and hope it continues. In our senior exit interview this year, we had a student who expressed that she saw a change in her class over the course of her senior year and felt that the change was a result of not having enough mental health supports as the seniors face post-high school changes and need to make decisions that will affect their futures and the beginning of their time as an adult. I also feel that we have seen the great difference that social media has made in our community to deal with those pressures, and we are needed to learn new ways to support parents and students, information to share with both parents and students on appropriate use of social media and how to stay balanced emotionally and with their time. So that was from my 7 through 12 counselor. Then I have a K-12 social worker, and she just wanted to add to Cynthia's statements that chronic absenteeism is a problem nationwide that Kimmer is also experiencing, and that she believes that the ramifications of high absenteeism later in life has not been studied or addressed. And I used to think that, I used to talk about suicidal ideation very rarely, a few times a year. Now it's a common conversation and at a much younger age. Hospitalization is a more common occurrence as well. And our special education and 504 numbers could tell their own story. We have so many more students that have mental health needs and or under IDEA for mental health reasons. So all three schools are constantly talking about how to reach the needs of the students. I believe we do the best we can with the resources we have. It's too bad that people outside of schools often do not understand how they could support our efforts and our students. So that's from Annie Crank. And I'll let Jen share.
Yeah, so I been thinking a lot about this. Sorry, I'm a little nervous, so. But K-6 school counselor, and part of my job is going into the classrooms, every classroom once a week, to talk about SEL, social emotional learning, or what are they, mental health, what's that one? The mental
Health and wellness.
Well, mental health and wellness. And I'd have to echo a lot of what Cynthia and Annie had said about those classes being pretty beneficial for the kids. I get a lot of feedback from the public out in the grocery store, at the coffee shop, where they'll come up and say, hey, Jen, your lesson on the box breathing this last week was really great because my kid's using it now. And I get a lot of repeats, like, can you do this lesson again, Mrs. Benson? It was really helpful. So I think I've been doing it for 7 years. And I also provide individual counseling for K-6 students, both in special education and through the MTSS, or multi-tiered system of supports process. And I have to tell you, from the 7 years I've been working here, I've had a huge increase of students, both special ed and regular ed kiddos, that have come in asking for services. I've had parents again out in the community ask me, my kid's really struggling from anxiety. They're saying that they want to kill themselves. I get a lot of those comments just walking around, probably at least once a week, which in my mind is too much. And this last year, so my kiddos range from 5 years old to 11 or 12 in 6th grade. And I've had to do 2 CAMS assessments on little kids. The CAMS is the suicide risk assessment that we use in our district. And I think 2 is too many. I've also had at least 1 year, starting with my 7 years, and those are little kids, and it's kind of scary to hear them talk like that. I'm sorry. I just also have not only do I see individual students, but I do get a lot of office visits from kiddos who are struggling emotionally that maybe haven't been put on my MTSS radar yet. And those are quite a few as well. I'd estimate I probably get 5 kiddos a week that come in crying, upset, anxious, nervous, depressed, suicidal ideation, things like that. That come in just needing to get regulated before they can go back to class. And there's a lot of outside things, families and trauma in those situations that we can't control, but at least they feel like they're safe in this school district coming to talk to someone. And my concern, or not even just a concern, but my fear is that, maybe somebody needs to come up into my office, but I'm busy with these other people, so I can't get to this kiddo. And that's probably the hardest part of my job, is making sure that I get to all of them, because I don't want to leave anybody behind. The other thing, the adults too. So we always talk about the kids, and that's kind of my first and foremost concern, is I want to make sure our kids are getting mental health help. But I have a lot of teachers that come into my office as well. And with, they feel stressed, they're anxious, they suffer from depression. And that's just in my little building. I don't know what Annie and Cynthia have out there, but it's quite a bit as well. And so it's a big job. It's a great job. It's my favorite thing I've done. I worked in community mental health probably for 10 years before I got here, substance abuse. So I've had a lot of outside experience before coming to work for the school district, but it's been my favorite place to be. And I don't know, I just want to make sure that we're doing everything that we can to help our population, to help Kemmer, and to provide them with the services that they need so that they can feel supported and able to teach, have our teachers be able to be in there and do their best, as well as provide an environment for our students that promote education or academic success. So thank you.
Question. Go ahead, Mr. Chairman.
Thank you, Mr. Chairman. I've got a couple of questions, and Jen, maybe I could start with you, if you wouldn't mind. You note that you see these kids. Are they coming to you independently, or are teachers recognizing challenges and referring them to them? How is it they end up in your office for advice?
So lots of different ways. If a student comes up to a teacher and asks to see Mrs. Benson, they're more than welcome to come to my office. A lot of times the teacher will notice, and this is the cool thing about our district, is that our teachers care so much about these kiddos. And so they're able to recognize when a student might be struggling. And then they also send them to my office. And so it's either teacher referral or a kiddo will ask to come up and see me. We also have the multi-tiered system of supports where we meet with parents. And sometimes I'll get referrals from the parents that say, hey, my kid seems to be, struggling with anxiety. And so they'll also request mental health services or counseling services.
Mr. Chairman,
Follow up. Go ahead.
So I appreciate the dedication of the teachers, but my question would be, do you feel that they have the tools they need to recognize, or is there a chance that some of these kids aren't getting identified and are falling through the cracks?
Oh, okay. So are they getting trainings
To screen, to recognize that a student may be having some troubles? Do you acknowledge that because the teachers care, they see the kids change,
Mhm.
but are we providing any training to help them recognize changes, or to be able to screen these kids and send them to Mrs. Benson?
Yeah, so we do have a couple of trainings at the beginning of the year. We also have a program called SABRS, which is our behavior intervention assessment, where they go through and kind of check each student off behavior-wise to see if they would screen for something like anxiety or depression or things like that. We also have a suicide risk assessment or suicide risk training at the beginning of the year that help or provide them with characteristics of students that might be backsliding or falling, or who might be suicidal. As far as in class, so I will do individual trainings with teachers to recognize signs of depression, signs of anxiety, so that if they refer a student, we go through and we talk behaviorally or emotionally, what the student is doing, how they're behaving, what they see. And then we go through and we kind of track, like, this looks more like anxiety or something like that.
Thank you. Follow up, Mr. Chairman.
Go ahead. Follow up.
So Teresa, in your the statement that you read from your 712 counseling, you talked, they indicated there's an increased hospitalization.
Yes.
Define that for me. What does that mean? Where are they going? Are they going like to a BOCES? Are they going to what type of
Chairman
hospital?
Baldwin, Co-Chairman Larson. So it would be both, but primarily our students who we've identified that need hospitalization end up at Primary Children's. So they'll end up at Primary Children's for an assessment to see if they are indeed maybe going to harm themselves. And then it's determined that they need actual hospitalization or outpatient care. But in our community, it's typically, since they're under 18, it's Primary Children's.
Follow up. Go ahead.
So that hospitalization initially is for an evaluation.
That is correct.
Refer for an evaluation, and then come what may after that.
That is correct.
Thank you.
Quick question for either one of you can answer, or both of you can answer it.
And I did want you to know I wasn't done presenting, so.
Yeah.
Okay.
So the question I have is that, you know, we've talked about the teachers, we've talked about students. I would a question about the parents. I know you have parents that say, hey, my kid's struggling, my kid has problems. On the other hand, do you see parents that are opposed or that have a problem with their kids talking with Jennifer or talking with somebody about mental health? Say, wait a minute, that's not your job. I'm just curious, if you have any parents coming to you with opposition?
No, I was just trying to think back. I mean, I'm not gonna lie, I've had parents who haven't been very happy with me because I brought up some, difficult subjects, but I've never been told, no, I don't want you seeing my kid. Most parents are pretty open. And even if now, understanding that certain personalities mesh with certain personalities, if it's not me, I always refer to Annie Crank. Also, we have the Care Solace where we could refer out for mental health. So if it's a personal thing and they don't particularly like the counselor, we do try to get them to somebody. And I've never been told no. So.
So Chairman Baldwin, Co-Chairman Larson, similar to Jen's response, we've never actually been told, no, you can't see my child, but they might prefer a different counselor that we've had. But that does lead me to my concern with the new legislation with having to have parent consent, even to, basically to deal with those immediate needs. And I did speak to this last year before it was passed. Especially more of our 712 students, not so much our K6ers, but we have 712 students that they seek the counselor to work through issues that they're wanting to work through. And, currently, if you're a counselor or a school social worker or school psych, we're trained to say that this is confidential unless I find that you're going to hurt yourself, you're going to hurt somebody else, or someone's going to harm you. And with that new statute, that's not a fact. So I'm really concerned that when we do tell students that, everything you disclose to me, I may have to tell your parent, I'm afraid that they're not going to open up and get the help that we can provide on a limited basis in our schools.
Okay. Further questions, committee? And if somebody raises their hand behind my head, you have to tell me. Questions, committee?
So Senator
Go ahead.
Baldwin, so I just wanted to talk about the things that we do to try to mitigate it. And Dustin Brown knows that we participated in Thrive, and we will participate in BAR. And BAR stands for Building Assets, Reducing Risks. I think it's hilarious that BAR is the name of a program for mental health in school. But and those are wonderful resources that I know the state's trying to provide, and we appreciate those. But again, we're talking about mental health of our staff. And so far, both of these projects, even though they're providing us resources, it's just adding to my already overburdened counselors. It's adding to Jen's plate, it's adding to Cynthia's, it's adding to Annie's, and it's adding to mine because we're the main people on that committee. So, and then to flip over, when pupil support in schools, which also counts our at-risk students. And I don't believe that we're meeting our needs. I'm here to share our story and to ask for more support for school systems, for DFS, that we can be more collaborative, working together, and even with our funding. But for example, we receive $159,000 for pupil support, which is our counselors. It's counselors are any gen ed personnel that we have hired to mitigate and work with students who are struggling throughout the day. We spend $326,555, which is a deficit of $166,904. So, when I testify at JEC, I try to make myself available. The students that we're getting today have higher needs. I've been doing this for 31 years. And it's significantly higher today than it's ever been. And I don't see it declining. I mean, COVID, I don't even like to use the word COVID, but COVID created a problem that we have yet to recover from. And then my other issue for support is chronic absenteeism. We have a student who missed 68 days of school last year. And we have multiple that miss 30 or 40, out of 175 days. We follow statute. We send letters home. We send letters to the county attorney. And we've actually received letters back from the county attorney telling us not to send us these letters anymore. This is your job. This is your responsibility. And it's like, well, I'm just following statute. So we don't have the support we need in our community to get our kids in school. And with that, I'll stand for questions.
Questions?
Mr. Chairman,
Yeah, Director, go ahead, sir.
Superintendent, first of all, thanks for being here and your testimony. With what you mentioned with the cost or your reimbursement for pupil support, counselors, et cetera, and you said there's a delta there of what the district is expending. So does that get made up from the general allocation? Essentially, where's that cost overrun coming from? What pot of money does that come from? We've had a lot of discussions about, calibration and these types of things. So I'm just curious for your area, how you make that work.
So correct. And the amount we mentioned,
Go ahead.
okay, I'm trying to read, Director Johansson. I only spoke about general fund dollars. We do spend more with special ed, but that's reimbursed. So I didn't mention the special ed funding because that is reimbursed. So it is through general fund and, it is a block grant. So we get a certain amount of money and we choose to prioritize that. So it just takes away the main area that we've reduced a lot in is professional development and our resources.
Mr. Chairman, follow up.
Follow up, go ahead.
Thank you
Director.
for that. That makes sense. And I appreciate you mentioning special education dollars too, because that's kind of a cut point, at least from my perspective with this issue on K through 12 mental health, where on the special ed side, I assume that's kind of, correct me if I'm wrong, this is Department of Health land vocabulary here, but more on your higher acuity or critical cases, the folks that are kids that are identified might be, using or enrolled in special ed services, et cetera, where what I take it that you're mentioning is more on the general population side, when you're doing things like screening or prevention or what have you, that's something that district by district could be prioritized differently. In your case, making it a priority and using general fund dollars to make sure that support is there. Is that a fair description or am I missing something?
No, Chairman
Go ahead.
Baldwin, Director Johansson, that is correct. The main reason we're here is the general ed population with these needs are growing. And we've actually had a judge tell us, well, put the kid on an IEP. And I wasn't in that room because Chairman Baldwin and Co-Chairman Larson know me. I probably would have spoken up, but it's like, I'm not an attorney. I can't tell you your laws. There are eligibility requirements to whether they meet or they cannot meet eligibility to be on an IEP. And a lot of the students I'm going to say that we're talking about probably are, trauma infected, socially maladjusted, and those may not qualify for an IEP. So if they do qualify, we put them on that IEP and we meet their needs through that mechanism. But if they qualify for a 504, again, that's unfunded. And those numbers are also rising.
Very good. Further questions, committee? Nobody behind my head with their hand up? No? Very good. Thank you very much.
Thank you, Chairman Baldwin, Co-Chairman Larson, and committee.
Thank you.
Thank you very much for coming. See, don't run away yet.
So help me as we talk about your staffing. So Jen, just based on your comments, I'd assume that you're probably either a counselor or a licensed social worker. So within your district, how many in this counseling realm are guidance counselors, and how many of them are from a different discipline?
Okay, so we have two that are, and she's a licensed practical
Cool.
counselor. Say
Licensed professional counsel.
licensed professional. Yeah. So we have two of those, and one is a social worker. And 1.5 is funded out of special ed, and 1.5 is out of general ed.
Right. Thank you.
Pretty good.
Thank you.
Thank you very much. See, Jen, I told you it wasn't that bad. No. I told her we were all nice. I lied to you. Thank you. Okay, what we're gonna do is we're gonna go all the way through the K-12 and then do public comment. So those who are holding public comment, just hold on until we get to the end of this first topic. The next item that I see on there is recalibration and recommendations for Joint Education Committee. Comments on that, Mr. Chairman?
So I would just share with the committee that we're going to be making some recommendations. I think at the end of the day, I don't know that we have anything really to talk about at this point, but Teresa talked a little bit about this in the amount that they have for pupil support versus what other funding they have in the block for providing counseling services. I think as we have visited with the LSO staff that helps with the joint education, they have suggested to me that as we consider what our policy ideas are for the state, that will, without question, will help then the consultants as they do their recalibration or their rebasing, determine what best practices are. And when it comes now to mental health services in the K-12 model nationwide, there really isn't a standout model that is adopted for K-12, and the recalibration efforts without some sort of policy suggesting this is what we think the state's role will be, they will then mold their recommendations around what they see geographically in our area, or perhaps nationwide if there isn't anything already established here. Having something in place of what we feel Wyoming's role is in that helps them craft their recommendations for recalibration.
Very good.
So we were kind of waiting for that a little bit. And so as we make recommendations back to the JEC, and we have talked last year and this year have kind of secured the idea that we feel it's the role of districts in providing mental health is to be able to screen, to intervene, and to refer. And then how do we fund that? Where do we get those? Would all be considered into that recalibration model.
Very good. And coincidentally, that brings up anyone who likes to do double task, would like to look online. The Joint Education Committee is meeting right now. And they're discussing the exact same topic that we're discussing right now, which was a little bit of a conflict as we had witnesses who wanted to be in both places and et cetera, et cetera. So if you're really bored and want to get online, you can watch them and see if they're nicer than us or not. But they're in Casper, is that correct?
Laramie, I believe.
Laramie? Okay. Go ahead, Mr. Chairman.
And Mr. Chairman, for the committee's sake, and maybe for those who are watching, we've been in touch, the Joint Education Committee and the chairman of this task force have been talking back and forth on the approaches for this, to where we're not finding conflict between the conversations and trying to find common ground as we move forward, not have to reinvent the wheel. So rest assured that we're having those conversations with them.
Yeah. Thank you, Mr. Chairman. Okay, that brings us to the next item on our agenda, and Senator Dockstader ran away. The next two folks on our agenda are somebody that Senator Dockstader and I spent some time talking with, and actually this committee has talked with Megan a little bit last year. So these are presentations that are going to overlap a little bit with some of the other topics we're going to talk about later today. But we felt that this is a good place to have them. If we can have Dr. Corso and Megan come up to the table, and they have some unique, effective concepts. Come on up. Come on.
Mr. Chairman.
Go ahead, sir.
And Mr. Chairman, we, the state has, working with Dr. Corso on a statewide plan to address suicide. And so the task force committee members will see that he reaches out past the K-12 conversation to more of a statewide, a community effort. We had kind of put him in this time slot. And you'll notice that he extends past just the K-12, and welcome him to do that, working with Jen Davis in the governor's office on a contract to work around the state on some things. So we acknowledge that you're going to, Dr. Corso, that you're going to be going out past that, and appreciate your willingness to stay in that time slot.
And we appreciate you both being here. You know, people tell me that it's a long ways to travel to Cameron. I don't know if it's any further than me traveling to Cheyenne, frankly, but it's a little ways over here. It's out of the way. I know that suicide prevention and the suicide issues are a little bit of a raw nerve in our local area here. We've had some difficulties, not just in our school district and in our city, but across the county. That being said, you guys arm wrestle to see who is going to speak first. Go ahead and introduce yourself and go ahead and tell us what's on your mind.
Thank you, Chairman, Co-Chairman of the committee. Good morning. I'm grateful to be here. My name is Dr. Corso. I'm a licensed clinical psychologist. I'm also a board certified behavior analyst and a suicidologist. So as the co-chairman said, we were thankfully awarded an opportunity to help bend the suicide curve in Wyoming more broadly. We'll talk about that in a few minutes. I want to make sure that the relevance of this dovetails with what the superintendent mentioned. So without further ado, I'm going to breeze through the first few slides. Just wanted to set the context. Slide 2 indicates that there are many, many more people who consider suicide than actually die by suicide. And I appreciate the sensitivity of this matter, particularly within this community, within broader Lincoln County as well. So we've got to stop looking at suicide as a mental health problem. We've got to consider that it is a social problem. It is no different than bullying. It's no different than homelessness or poverty. It is not people sort of going crazy. I'm using air quotes here for folks who can't see. Next slide. We know that Wyoming continues to struggle along with Montana, Alaska, New Mexico. They tend to be in the top 5 states with the hardest suicide rates per capita. Next slide. Yes, please, sir.
Your slides indicated that we're still number 1. We haven't moved much, but we're not number 1 anymore, right?
So, sir, last year you were not number 1. You went to number 3, but now you're back on top, unfortunately.
You're a bearer of bad news.
I am the bearer of bad news. I'm fired. Burn it. Burn it. When we look at how the Wyoming suicide rates compare to the US, it's number 1 currently. It is the 2nd leading cause of death for ages 10 to 44. It's the 7th leading cause of death in Wyoming. And the rate is about double the national average. Next slide. When we look at that, drilling down to the child and adolescent population, we know that among 15 to 19-year-olds, the rate is more than double the US rate for that age group. We know that the suicide rate was highest for ages 20 to 24 in Wyoming. And so if we flip to the next slide, what we'll see is that sort of a heat map of which counties have the most difficulties with youth suicide. Again, I've included this information more just for background information to set the stage, not because we're going to do a deep dive. Next slide, please.
Go ahead.
So as you get into this a little more in your comments where you said trying to help us understand this is a social problem, not a mental health problem. Can you, as you go through this, help me understand that a little more?
Yes, sir.
I'm don't know that I'm making the tie there. So if it's a social problem, I'm trying to understand what causes that social problem. So
Perfect. Great,
Okay.
great
Thank you.
question. So looking at it this way, I'm going to use a very precise measurement tool, and that is my arms. So this many people think of suicide every year, but only this many people attempt and this many people die by suicide. What it means is it's a much more common human experience than we are used to believing because people don't talk about it. Now, when you mention the word cause, we try to be careful with that word and we say, what are the contributing factors? When people consider ending their life, it tends to be when their self-identity is threatened or diminished, when they have some sort of decrement in their meaning and purpose in life. So we all wake up in the morning and think something to ourselves about why I should bother getting out of bed. It might be faith-based reasons. It might be our personal career goals. It might be our role within our family or the broader community. When people question that and they have a very flimsy sense of why they should bother going through a day, that's the precursor to the suicidal thoughts. And so among kids and adolescents, it's quite common and frankly normal in human development for them to question their self-identity because it's developing, especially in the tween and teen years, right? However, the world is a bit different than it was when most of us were younger. The internet, they learn much more, they're exposed to much more. In some ways, they are ill-equipped to swallow all that they are fed through social media, through popular culture. And so their self-identity when they question it, they're also aware that suicide exists, and they're aware that people have successfully, I'm going to use air quotes again, because we don't consider it a successful behavior or pattern, but they've sort of gotten out of their misery by ending their life. Does that answer your question, sir?
Go ahead, sir.
It does. So do mental health challenges lend to or cause the ability to resist or refocus, whatever the proper term is? I mean, does that have an impact, or are we just missing the boat by saying we should improve mental health would improve suicide reduction?
So the answer is both. So there is a certain pretty high percentage of kids who attempt suicide or die by suicide that are within mental health treatment. That tends to be because parents, teachers, and others are very quick to get our youth help. However, the same is not true among adults. There are many adults who die by suicide who are not within the mental health system at all. So if we rely solely on the mental health system as the vehicle to improve this, we will continue to fail. Frankly, that's what we've been doing for the last half century, and unfortunately, it's not working. So when we broaden the aperture, broaden the lens, and look at it as more of a social problem, I think to the point you're sort of intimating here is that it's about connectedness. The more we increase connectedness in communities, in families, whether you're an adult or a child, the more we're buffering against that suicide risk. It's when people are hopeless. It's when people feel like there's no light at the end of the tunnel, that their current difficulty in life will not change. That's when they have those thoughts.
Thank you. Very good. Further questions before we proceed? Go ahead, doctor.
Great. Thank you, gentlemen. So looking at this slide, this is a survey of grades 6 to 8 students in Wyoming. And if you look at the percentage of those who have attempted suicide one or more times, statewide, the average is 9.4%. And it looks like there are about 8 counties that are above that. So that's just more for your reference. And sir,
Go ahead.
Sorry, Mr. Chairman, just
there's a lot to unpack.
It's a
There's
big
lot to
issue,
unpack.
right? It's a
Certainly.
big issue. And so do we have more information on the demographics of those that
We-
you could maybe provide to us?
We do.
Okay.
And these are not my data. This is from the
Right.
Wyoming Prevention Depot, but I can help get those for you, sir.
Thank you.
Very good. If you can just get that to us in an email, make sure it gets to all the committee. Okay, go ahead and proceed, doctor.
Great. Next slide, please. As we pan back and look at the population as a whole in Wyoming, what we see is that 10 counties are above the state average for suicides. So if we want to try to look at hotspots and where we want to focus our efforts, it makes sense both to be fiscally responsible, but also to be effective with our efforts. Next slide.
Hold on, I think the co-chair's got something for us.
Well, I just think that they're fascinating slides, Mr. Chairman, but I found it really interesting that in your previous slide, when we talked about, you look at those 10 that are above the average, then you come over to this and you look at Hot Springs County and, but yet their development has just been in the past few years, it appears to me. And so, which then is the question, what's going on, right?
That's true. Remember that our efforts to collect and report data continuously improve. That's one set of variables. Remember that another thing is if they have 5 or fewer suicides, you'll see this sort of
Right.
asterisk. Those data are kept highly confidential for privacy purposes to the families and others who have ended their lives. So the data can be a bit misleading, and they're complex at best, sir.
And I would add to that you know better than I'm preaching to the choir here, is that as we get more of a spotlight on mental health well-being, that's and Kip shaking his head there. No, we talk a lot about mental health, and mental health is not mental health problem. Mental health is, we all in here have mental health. Some of us have a problem with mental health, like I won't point myself out, but mental health is a mental well-being. So when we talk about mental health, it tends to say people, oh, mental health problem. And that's not the case. Everybody has mental health, right? Some of us it's good, some of us it's worse, some of us it's real bad. But mental health is just like physical health. Some of us are more physically healthy than others. And we need to treat the ones who are having a problem or find a problem. You know, I don't want you to eat so much T-bone steak and we're going to keep your cholesterol from getting bad.
Precisely.
That,
And of course, we know they're intertwined.
yeah,
So-
and the
so-
hotter the spotlight gets, the better our numbers become, right? So
Yes.
Mr. Chairman, so if you wouldn't mind on that one that says suicides by county, there, the one that you're on, if we would just look at Hot Springs County in 2020, the 83.7. What does that, what is that number? That's not number of suicides. Is that percent of average? What is that?
It is the number of people per 100,000. That is the standard ratio that epidemiologists use to study suicide, because from a, I might put you to sleep, Chairman, a co-chairman, but from a statistical perspective, there are 330 million Americans, but there are only 47,000 suicides in America. So it's it's 0.001%. So it's such a small rate, even though it's still the top 10 causes of death. So they use a ratio of this many deaths per 100,000 individuals to help standardize it.
Very good. So they adjust the reported number from the county, do that calculation to represent what that would be per 100,000.
Yes, sir.
Thank
So
you.
that
That
these are
helps. That's
apples to
very
apples data.
Mr. Chairman,
go ahead, Rector.
just a little color commentary for the task force, because this is an issue we've dealt with and tried to work on for years. Would caution the committee on the noise of suicide data absolutely has to be considered. So when we look at trying to bend or reduce the suicide rate, it's challenging from a data perspective because you're constantly chasing noise. So for example, in a county in Wyoming where we have prevention coalitions or efforts that go on, in 1 year, you could celebrate a lot of success because you reduced your number of suicides on a raw count by X number, and it's celebrated. And the next year it goes up by 90% because these numbers are very small. I'm happy to share this with the task force. The past 2 years, we've used a little bit more statistical method in our suicide reporting to model what the trends by county and in the state have looked like going back to the early 2000s to try to predict, absent any interventions, what would happen. Again, using a sort of a modeling approach. And then look at with more certainty, and I will italicize the word certainty, to look at where we're seeing benefit there. So just looking at raw counts and even looking at rates, as the CDC does, is not extremely helpful for analytical purposes in Wyoming. So I'm happy to share that new approach that we've taken the past couple of years in the Department of Health to model out our suicide rates and our trends going back for the past 25 years or so.
Mr. Chairman, could we ask, would you make that available to us?
Happy to send it out now.
And that brings to mind a question. This is very, we could stay all day on this one topic, but let's not. But that brings a question to mind about how many deaths are not recognized as suicide, that are actually suicide. What if you just had to guess, and this is just a guess on your part, doctor, how many deaths out there are actually suicide that are not recognized as suicide, that there's probably no way to prove that they're suicide? Are we missing a larger number on the grand scheme of things?
We are, especially when we consider deaths by overdose, especially the opioid crisis. It could be up to 25% of an underestimate of the suicide rates, because it's very hard to prove that when someone took too much of an opioid, whether or not they were thinking of killing themselves at the time. Obviously, if there's a suicide note or they've spoken about it, then we can deduce that. But you're correct.
Very good. I won't make you speculate anymore. Go ahead and proceed.
I'm more comfortable with the data versus speculating, but appreciate that. So if we go to the next slide, PROSPER is the proactive reduction of suicide in populations via evidence-based research. So it integrates all of the evidence-based research out there to try to move upstream and reduce the factors that drive suicide. As you can see on the map here, for the past 2 to 3 years, we've been in Teton County. In the last year, we've been in Lincoln County. We are in these other 6 counties now as a result of this effort with the governor's office. Because Natrona is adjacent to Washakie and tucked right at the corner of Campbell, we've decided to branch out into that county as well. It's also a fact that sadly Casper is on track to have one of its worst years yet. I believe it's 14 suicides as of now. And as Director Johansson did mention, we have to be careful with raw numbers. They're misleading, but we certainly would rather be safe than sorry and do more action rather than less. Next slide, please. So the goal here, and I'm recognizing that our time is getting short. Our goal here is to change the conversation. We want to make sure we have realistic goals as we work across these 6 counties. The idea that every suicide is preventable does not hold up to data or history. So we want to disabuse each other of this idea that every suicide is preventable. There's no evidence to suggest that that's possible. And so as a part of that, we'd like to have community members, law enforcement officers, teachers, parents, physicians, nurses adopt more realistic goals about what we can accomplish while trying to help others in distress. And what we can accomplish is to reduce risk, but we cannot save everyone. And one of the most unfortunate things about common approaches to suicide prevention is our professionals, whether that we're talking the medical community or educators, as the superintendent mentioned, they often act out of fear. They're not acting out of confidence. We want them to be able to act out of confidence. And that means having high quality training and having the comfort and confidence of using those skills. In late April, we conducted a few trainings up in Afton. And there was a principal of one of the schools who sat in and took the entire full day course of Prosper and actually used it the next day and said, oh my gosh, this works. And we said, yeah, we know that's what happens when you learn a set of skills and have high confidence and have high comfort using it. And that's what happens when we follow the research. So we want to empower both youth and adults to help themselves. We don't want to dictate what they should do. We don't want to remove their rights. We don't want to be heavy-handed because frankly, we've been doing that for several decades and it's not working. We want to focus on people's strengths and values and culture and use that to our advantage. And if folks in Wyoming are very prideful about their sense of independence and self-reliance, then that's how we want to help them to self-manage their suicidal symptoms. What we found working in Lincoln and Teton is many parents feel very disarmed when this conversation comes up. If either a teacher brings it to their attention or it comes to their attention somehow that their child is thinking of killing themselves. So we want to also work within the communities to boost their confidence and their skills. Next slide. This is a bit of foreshadowing. Helping someone who is suicidal is no different than helping someone who is having a heart attack. It's just a different type of crisis. And we know what, next slide, please. We know one size does not fit all. We touched on that already. Next slide. Next slide. Next slide. We'll go to slide 15. Let's go there because I think that's where we should probably wrap up. Prosper targets suicide according to Wyoming's behavioral health redesign strategy. So if we just look at access, the goal that we have in these 6 communities is to decrease psychiatric hospitalizations, decrease ER visits. There are many people who take this better safe than sorry approach to trying to help our youths and our adults. And the problem is that unintentionally punishes their help-seeking behavior. It is not fun to go to the hospital. It is not fun to sit in the ER for 16 hours until you're seen by a specialist. So if we can avert that and give them more support at the point of contact, then that will actually engender more engagement in all the resources that our system is providing. Affordability, fewer hospitalizations, fewer Title 25s means dollars saved. Quality, when we boost clinician confidence, competence, and comfort, we improve the youth's likelihood and the adult's patient's likelihood of tackling their distress and their crisis. When it comes to innovation, we talked about empowering. That includes educators, clergy, first responders. And then there's a bit of a cultural shift here, is talking more about it. Some different ways to talk about it. You can love guns and love suicide prevention. If that's the first time you've heard that, let's keep talking about that. We've got to lean into our values. If people appreciate their firearms, we're so bombarded often with these one-size-fit-all suicide prevention programs that say get rid of the guns. That's a non-starter. That's not going to work in cultures that really appreciate firearms. So let's lean into the culture and figure out how we can do both. We also want to look if we can flip forward to slide 17, I
We got
believe.
a quick question here.
Oh, yes, sir.
Go ahead, Chairman.
I've been waiting for the last one and you're skipping over it. So tell us about the Good Samaritan Law revisions.
That's exactly where I was going, sir.
Okay.
Excellent. So there's a lot of talk currently about Wyoming's Good Samaritan law with regard to Narcan and having law enforcement officers, things like that. But one thing it doesn't mention is that people are covered if they're helping someone with suicide. Slide 20, please.
Interestingly enough, Chairman, that's on our agenda for next week at Labor and Health. So
Excellent, excellent. So I will say that Missouri has a law where Section 4 explicitly mentions that if you are a member of the public who is trying to help another member of the public who's in a suicide crisis, barring gross negligence or something else harmful, that you are not liable. It's really important for our community members, parents, teachers to have that reassurance and that protection. It destigmatizes while also encouraging people to help. And then my last comment is on Title 25. We can have our law enforcement officers and first responders do much more to avert Title 25s. They are trained in risk and threat assessment. They are trained to analyze behaviors. They are trained to de-escalate with words versus use of force. And I'll pause there. Thank you.
very good. Any questions, committee? There's nobody behind me now. And I would note for the committee's sake that Franz did just send us that data that we asked for, so it is available in your email. Go ahead, Mr. Chairman.
So some of us were at that National Mental Health Conference and took this for mental health first aid. And my take was that they recommended that that would be an appropriate training for law enforcement to kind of help de-escalate. Would you, we took it, understood it, but would you agree with that? Is that the type of resources we want to provide for law enforcement in these situations?
Mental health first aid, CIT, ASSIST, Safe Talk, QPR. These are fundamental programs we've been doing for years, and they are important. But the underlying concept here is that we've been doing them for years. And they don't specifically target people's confidence in approaching someone in distress.
Well, and I guess, Mr. Chairman, thank you. I guess that was my question, because you've got me off on this social thing. And I'm trying to make the connections between what we're providing to help intervene and de-escalate a situation, and making sure that, to your point, we've been doing it for years, but are we having success with it? And then if we're not, then how do we alter the training for law enforcement officers, right?
Yes, sir. So good question. So we're having success because it's not that it's the wrong thing, it's that it's not enough. So it is the foundation, the fundamentals, but we've been doing the fundamentals, and what we need to do is step one step farther and do a bit more. Yes, sir.
Go ahead, sir.
Mr. Chairman, Dr. Corso, bystander intervention training has the ability to increase confidence. Is there anything that meshes in this realm from a bystander intervention that increases confidence and increases the ability to support crisis, near crisis events, to your knowledge?
That's what we've done with Prosper, quite frankly. That's the unique value added. And aside from it being culturally relevant versus this one size fits all, telling everyone who's in Wyoming, go get help. They're not going to. They don't do it with their health. They would much prefer help themselves. And so that's what we'd like to do is lean into their culture and value that.
Thank you.
Further questions, committee? Okay, thank you very much. We pass the torch to Megan. Megan, welcome back.
Thank you. I would like to just, before I even start on my presentation, give a little anecdotal evidence to what Dr. Corso is talking about. My husband is a first responder. He's an advanced EMT. He was fishing at Flaming Gorge. He was in, and so I'm really grateful for the Good Samaritan law, because he pulled the boat out. A little 12-year-old boy ran in front of a truck right in front of him. He had to give life-saving measures. They did not have, they only had beginning EMTs there. He knew what to do and had a chopper in the air. And he came home really upset because he felt like this kid was just not going to make it. And gratefully, miracles happened, and that he got a phone call that said, hey, what you did in the field actually saved this kid's life. They had 20 minutes till they got to the ambulance even came. And then another long time before the helicopter landed at the hospital. He came home really worried. He was like, I was outside my scope of practice. And I said, no, there's a law, the Good Samaritan law. It's okay. And then we've heard since then that this little boy is going to actually make it. So we're really excited about that. One other anecdotal evidence from Prosper is that my husband, in this capacity, there was a suicidal person in the prison, and he got called in, and he used these measures that he learned here. Not only, he's a very empathetic person anyway. And so, but he used those measures, and just we received a letter from the county telling him, thank you for going above and beyond in this situation and being able to help this lady out instead of having to take her to the hospital and do the Title 25.
You be sure to
So-
tell your husband from us good work.
Well, I always have to shout out for Travis because he's pretty cool. So I am here. I am on a practical note. So my specialty is in the trenches, what actually happens on the ground. And so today, I thank you, Senator Baldwin and Representative, or no, I'm going to say it wrong, Chairman. Can I say Representative either way?
He'll answer anything, make him call him anything.
People always call me Mrs. Osmond. I'm like, oh, just call me Megan. I'm just Megan. There's no dressing that up. So my comments are just going to be real applicable. This is application. So I will leave the statistics and the theories up to Kent Corso and Mr. Brown, although I probably call you Dustin Brown. But then I'm going to show, I hope I can demonstrate what actually has to happen on the ground in the trenches. And so my comments really are today about connecting Wyoming communities. If you'll switch the slide, please. So the first thing I want to talk about is building infrastructure. So I feel like what really needs to happen in Wyoming in order to address this issue is to really build infrastructure. What we do well in Wyoming is provide resources. But what we do poorly in Wyoming is connecting those resources. So we have preventive, suicide prevention specialists in each county. We have, I sit on a human resource council, and there is people with resources and opportunities for the public there. But what's happening is they're not working together. There's very little connecting of those resources. Next slide, please. So the infrastructure, in my estimation, needs to happen inside the school communities. So schools connect communities, especially in rural Wyoming. In rural Wyoming, I would say the majority of the population is going to connect through the school system in some way, shape, or form, whether that's athletic events. I don't know if you guys are all Wyomingites, right? Small town people. Everybody shows up for the basketball games, the whole community. You know what I mean? Now everybody comes to the football games, whether it's athletics or they're using the school buildings for community events, because that's really one of the only buildings in that area that can house that kind of thing. At some way, shape, or form, the schools are really designed as the center of our communities. And therefore, the infrastructure that we build for mental health needs to be housed right there where all the communities connect. Next slide, please. The other thing I want to talk about is the school system, and our good superintendent alluded to this just a little bit, but I wanted to really drive this point home, and that is that our school systems are kind of built like an engine, and it takes all sorts of moving parts in order for that engine to move forward. They are doing so much, and so this engine has to run smoothly. Every gear has to work with the teeth of the other gear, and it has to work really carefully in order to make this giant machine move forward. And when you create a program outside the school system, it's like taking a bolt and throwing it into the engine. It just grinds to a halt. Just grinds to a halt for a minute. Then they'll take that bolt and they'll say, okay, we've got this system. How are we going to build it in? At our last meeting, the superintendent talked about that. She said she was so thankful for the change of standards. And then she made the comment, And we're working on figuring out how to make that work in our systems. That's how it goes, right? In schools, they have these things happen outside of them, and then they have to take those gears and they have to figure out how to make it work inside their system, their automatic system. So in my estimation, the programs for mental health for K-12 must originate inside the schools so that it can be built properly and fit and integrate with the systems already in play. Next slide, please. I did, with the permission of Dustin Brown, I did my own independent district interviews for Project Aware. I was fascinated with the infrastructure and I wanted to know if it worked. And so I called many of it's in the materials for this meeting if you want to look at the full report. But I called many of the Project Aware project managers. And then I also called people who were handling this, districts that were handling this outside Project Aware. I wanted to know what was working. And this is the result of my research. Basically, inside and outside of the Project Aware, the number one priority that they tell me has to be in place in order for this to work is some kind of coordinator. Dustin Brown in Project Aware calls it the community project manager. And so that person, and outside Project Aware, if it's going to work, it has to have somebody who is in charge of this and working this, and that's the coordinator position. That coordinator position has to have direct communication and in the know of everything that's being built for this school system. So they have to be at a district level, understanding how this engine works, how all the pieces work together, so what they build can fit in smoothly. So that's the number one priority. The second priority was the provider contracts. So this person, the coordinator, then works to set up the provider contracts, because in a school system, if you have a student in crisis, which is what in the MTSS system they call them tier 3 students, they're in crisis, they're suicidal. You can't just say, oh, hey, you know what? I understand you're having a problem. Give us 3 weeks, maybe 6, and we'll get you some help. It just doesn't work that way. And so those provider contracts and the way to get the kids to those providers needs to be ironed out and really, really smooth. The third priority was the gap funding. So the provider contracts get paid generally, and Dustin Brown can talk to this much better than I can, but through insurance. But you're always going to have those students who are not covered through insurance, or their insurance doesn't cover counseling. Next slide, please. So I created this as kind of a visual to try to help everybody understand kind of how this Project Aware works. And I'm not going to talk a lot about it because Dustin already did, but it's kind of like a circuit board. And the energy comes in at the top, and these are the support systems. And then in orange, this is your think tank. And your think tank, all of these systems have to be at the table in order to design something that's actually going to fit inside a school system. And then on the outtake, or the energy, where the energy is coming out, are these specific things that need to be built in. I joined Stand for Kind after I built my app. I spoke to you guys last year about my app that I built called Kindness Matters. That's an app designed to improve a culture of kindness in our schools. And since then, that's been a year, and I've partnered with Stand for Kind, who has done this for 15 years. That's what they specialize in. They go into schools, they change the culture, and they have several programs in which they do that, most of which are free, because we chase grants and sponsorships like nobody's business. So we try really hard to offer all the a la carte system that we have for free. So Stand for Kind programs, I'll talk about that a little bit more, but those are the student programs that can come out of this think tank. Programs like Prosper are the adult programs that can come out of this think tank. A lot of the times the kiddos that are coming into school are coming with problems that originate from home. And so those are being handed over to the school to solve. And so a lot of times what these community project managers determine is, hey, we need to hit the adult population. So let's figure out how we can use this think tank to get something like that into our community. And then the third thing that has to come out of this is teacher support. Nothing that we do, if it's not supporting teachers, is gonna really support the kids. It all centers on those teachers and boosting them up in their capabilities. Next slide. Yes.
Go ahead.
So you made the statement that these problems are being handed over to the schools.
Yes.
Who's handing them over?
So let me give you an example. So a student is, or a parents are dealing with a really difficult divorce. And maybe they don't have the school or the skill sets in order to deal with this. So the kid comes to school a mess. And so then that mess then becomes the schools and the counselors' efforts to try to help the student overcome.
Well, Mr. Chairman, and so I appreciate that they may be on the receiving end of a
Yes.
bad situation, but I would argue that the intent is not intentionally to hand it over to the school to resolve, which is what I thought I heard you say.
No, I'm sorry. Let me clarify that. What kiddos are coming to school with, often the problems they're coming to school with can originate from home. Not always, but can. This slide is, I was asked to give a scope of practice for Stand for Kind, and this is what we do. So essentially we start with a school assembly. This is a tier 1 approach. We have an array of speakers and bands on retainer, and they come in and the administrator chooses whatever topic that they need to address or what they're trying to do. And the school assemblies, we create these assemblies and these experiences that really kick off this kind of thing for the schools. The other thing that we do is a tier 2 approach, which is your smaller group of kiddos, and that's what our ambassador groups hit. And our ambassador groups are groups of kiddos that need some extra support, but don't necessarily need a lot of one-on-one counseling. And those groups we put together to be service groups that essentially they identify the issues in the area and, in their schools, and then they come up with solutions themselves to address those. And those are really fun to watch. Then we have curriculum, a whole set of curriculum. And then we have teacher staff trainings, and then we have ambassador camps. We've got one next week down at Bear Lake that I'll be a part of. And these are leadership camps teaching the ambassadors how to go back to their schools and set up the systems that can help themselves and their peers. So we really love those. These are also the states that we are in. And we're just starting in Wyoming. We're really, really heavily involved. We're a line item on the legislative budget in Utah and California.
What does that mean?
We receive about $300,000 from Utah every year. It's just a year in and year out. And when schools call the Utah Department of Education and say, hey, we're really having a bullying problem, they refer that school directly to us, and we go in and set up the programs to help.
Just a quick question. When you say to us, when they refer that to us, do you have somebody in Utah, or is that specifically to you, or in each one of these states? Do you have somebody specifically in each state?
So we have our huge cohort in Utah. We also have a huge cohort in Texas. And so, did I even put Texas? I think I forgot. to
What's
put Texas
huge?
on. So in Utah, there's 801 ambassador groups. Let me quantify that. In Texas, we have about 8 different districts, including all of their schools, K through 12. In Utah, it's more like, I think it's closer to 40 to 50. It's, and I can get those exact numbers, 50 districts. So you have almost the entire Washington County, almost all of the Wasatch Front, and then several outside of all of that is what we do inside of Utah. Texas has a team on the ground in Texas. California has a team on the ground in California. Utah has a team on the ground in Utah, and you're looking at the team in Wyoming. I am it in Wyoming.
We're glad to have you here. Another quick question is that 300,000 that state of Utah gives to
Yes.
do that. Have you ever expended all that funding? Or
Oh,
what do you typically spend, and do you want
So-
more? I'm not on that legislature.
So you can see the school assemblies right now. Those are our numbers. We could double that if we didn't run out of money. So right now, we just, in the last month, coming up to August of this year, we added 2,000 more schools. So we go as hard and as fast as we can until we run out of funds. We have several grants, federal grants that we run off of. And then we hustle after sponsorships.
Mr. Chairman.
Go ahead.
So the question was on the 300,000 in Utah, and you referred that you added 2,000 schools in Utah.
No, that's nationwide. Those are our brand new
So-
schools that are coming in.
Okay, so I was trying to
Oh,
make,
let me quantify. Yes, we use up that $300,000 pretty fast just in Utah. And then our federal grant has specific states. And so then it'll tell us how much money we can use for this state, this state, this state. This year, so it's due, the grant is due on June 20th. And we included Wyoming in that grant proposal for the first time this year. So we're hoping to have a set of income. In addition to that, I secured a grant last year from the Hughes Charitable Foundation, and I still have money left over to use for Wyoming. That's a Wyoming designated funds that we can use.
Mr. Chairman.
Oh, sorry, in 1 second. And I would just ask for, if you can get those, whether you get that grant or what grants you've got
Yes.
specific to Wyoming, if you can get that to the committee.
Absolutely. The grant is due on June 20th, and then I'll find out when we find out if we got it and if Wyoming's a line item in that, and I'll let you know for
Very
sure.
good. Now we'll turn to a much more important member down the road. Go ahead, Director.
You're too kind, Mr. Chairman. More of a kind of epistemological question here. Sorry for using a big word,
Yeah,
but
you might have to define it for me.
prevention work is tough, especially on the evaluation side. We live in
Yes.
that world, and frustrating for decision makers in determining
Yes.
efficacy. And so it's often rooted in kind of output-based strategy.
Yes.
We're doing this thing. A coalition or a specialist or a community is engaging in this particular training or this particular assembly or this effort. And I'm seeing those numbers here that could be replicated in Wyoming, but you mentioned some of them from your other jurisdictions that you all work in.
Mhm.
So what do you look for in efficacy? We do these outputs, we do these things, and very rarely in prevention work can we, Kent knows I'm a healthy skeptic here, but I think it's important because there's a lot of investment that goes into this
Amen.
world, both with state dollars, federal dollars, community dollars, school dollars. And so I think it's important of at least being transparent of what success looks like,
Yes.
what, even if we're not drawing causal connections, what correlations are we looking for? So I'm curious in, taking a table or a visual like this with the number of school assemblies, the number of participants, the number of trainings offered, what do the folks at Prosper look for on a month-to-month, on a year-to-year or multi-year basis to try to draw a dotted line towards some sort of success?
I love that question. I'm so glad you asked it. It's Stand for Kind, we're good pals, Prosper and Stand for Kind, but what we have found to be the most effective and what I used in my Kindness Matters app is a measurement of perception. Now, I know that's also slippery. I know that perception can be slippery, but this is a social science, not a hard science. And so you have to, and that goes a lot with Dr. Corso, what he does, and the topic that this is a social issue, not so much a science issue. So we measure perception. We measure 10 different categories of perception inside our school. So we give a survey to the kiddos to begin with, and this originated with my Kindness Matters app. We do that. It's so fascinating. I would love to give you the research on it. So it's so fascinating because in every school, it looks different. So for example, one school, in fact, it's at my school, so Star Valley High School. I grabbed, in my ambassador group, I grabbed a whole bunch of kiddos who were service leaders. I wanted to see what we could do there. So we got service leaders. We started implementing these programs. I did the beginning survey and the end survey. The thing that improved the most in a 6-week period, the perception that improves the most was empathy, caring, considering. That was now I did it again with a health class, and we did it in a mental health unit in a health class. And those kiddos, the results, the perception, the areas that improved the most in a 6 to 8 weeks period was staff, the view of staff and family and community opinions about the school. Now that's interesting. So it just depends on the kiddos that you're doing. So I can see what you're saying, and I understand the issue is that these are slippery numbers. And just as Dr. Corso said, they're slippery numbers. It's really hard. But because we have found that the best thing to measure is perception over time. So we are in the business of increasing a positive culture. We are in the business of adding meaning and purpose to school. We are attacking it on the positive side instead of like hitting suicide, anxiety, depression. We're saying, hey, look at all of the reasons that are worth living. Hey, let's put in groups together that really enhance your experience here. Hey, every time you walk in the door at this school, you're going to say, I actually like being here. So that's what we work to accomplish, and that's why we measure perception. Does that make sense? Okay.
Very good. Go ahead and proceed. Oh, go ahead, Rector. Of course.
Thank you, Mr. Chairman. I think I got lost a little bit. So if we could back up just a little bit. So you're talking about the scope of practice in assemblies and trainings. When you, the work you actually do when you go to do a school assembly, what does that mean? What is it that you are communicating to the kids in that assembly? And when you say teacher and staff trainings on what? Because I've heard you throw out bullying, I've heard you throw out mental health. So could you please give a little bit more detail to that?
And the reason I don't get very specific is because we design it per school. So when a school calls us, like I'm just going to give you an actual example that happened a month ago. We had a school that called us in central Utah. It's a rural school. And what they said, we are having all sorts of problems. We need you to come in. So we came in and we had conversations with the administrators, with the student leaders and the teachers. And then we gathered this information. What we deciphered down, and as we worked with them to understand what was wrong, they were having a bullying issue, but it was a perception of bullying that was the problem, meaning they weren't coming from bullies. They were coming from their friends. And you have to understand, in a rural community, all of the training is, oh, if you're being bullied, block the phone call or don't talk to that person or walk away. Well, guess what? In a small school, you don't get that choice. You don't have that choice. There is only a few people, small amount of kids there, and those are your friends. And so we designed the program to come in, and we did an entire curriculum on friendship and building friends, understanding communication skills. So then we design the assemblies. The administrator will say, I really want you to talk about resiliency. We come in, we talk about that. We have a band, we kick it off, and then they have like a year-long program where we can do these different trainings through the year. It's totally up to the administration. It is not a canned program. The administration are the ones that just say, this is what we need, this is how we are going to do it. And then we come in and help them design that. Does that clarify that? Okay.
Very good.
Perfect.
Continue.
I just have one more slide and we can move on. The last thing, we have infrastructure. I really feel like it needs to be housed right inside the school system. It needs to be designed to fit into the school system. And this is the last thing that I feel like we really need to work on in Wyoming. And that is to turn on the light, to shine a light on what's already there. So my experience in these communities and on the Human Resource Council, just like I said before, we have a lot of resources. They are not necessarily connected, and there is no real viable way to get this information of what's available to the people. So our S4K Connects app has developed from this problem. Once again, these are issues that we find in the trenches, and then we try to find solutions to meet those needs. The S4K Connects app is a mental wellness app provided to businesses to give their employees mental wellness tools, and it also has local resources for local people. In Wyoming, we have that set up as countywide, and I've been in close communication with some of the prevention specialists to start to provide that. And then we have an integrated feedback loop. So it's crowdsourced. So when you have a neighbor who is, you know, putting together a walk because she lost her son to suicide, and she wants to let the community know that, hey, there's this support group, I'm your neighbor, and come, then that information is getting into the hands. Right now, most of these entities or these resources that we have, in order to get the information out, they have to use general platforms such as Instagram, et cetera. And I don't know about you, but every time you get on there, you get lost in information, and the information is just not making it to the end of the row. And so this is a way for that to happen. And that is the last solution that I have to offer for today.
Mr. Chairman.
Thank you. And it just may be a redundant things, but I was trying to figure out the difference between school employees and local school employees.
So just, did I put it twice?
Well, I was wondering, that's what I was just trying to.
Did I say
figure out.
business school employees? I think I was talking about just your, that was probably just redundant on my part.
And then on the cost, the percent of cost is a tax deduction. Is that on your federal
So
tax?
this is when we have a super low cost for our S4K Connects for businesses. And a percentage of that goes right back to community programs. So a percentage of that is a tax deductible percentage that goes to either Stand for Kind or community events like Prosper, speakers, bands, anything that's going to just bring communities together.
Well, but you say that a percent of that cost equal a tax deductible donation, that'd be on your federal tax.
Yes.
I assume.
Mhm.
Thank you.
Yes, we issue those tax deductible forms back to the businesses.
Thank you, Mr. Chairman.
Okay. Further questions, committee? Looking both ways. Somebody else is looking behind me. Nobody has their hand up. First of all, thank you very much for coming. It's nice to hear these things. You know, we talk about downstream and upstream a lot, how to treat these things, mental health issues. It's nice to hear the upstream side rather than the downstream side all the time. So it's nice to hear that. We'd like to catch them before they jump in the river, so to speak. So we appreciate you both and thanks for coming. Okay, you're out of the hot seat. Okay, ladies and gentlemen, I think we're kind of going to dovetail the next two things together, because the next one's talking about recommendation about the bar model. We've touched on that just a little bit this morning already. And then the next one is the Project Aware recommendation. What I'd like to do is maybe turn to the Department of Education. And I know Dustin's up and we got a couple of people online as well. So Dustin, what we're going to do here is we're just going to jump in and kind of dovetail these two together, the bar and the Aware, if you wouldn't mind. And you can sit wherever you want. You can sit there, you can sit there, you can sit outside. Go ahead.
Yeah, thank you, Mr. Chairman. All right, so from the Wyoming Department of Education, Superintendent Dagenfelder is really focused on empowering parents. And with the empowerment of parents, we're looking at, as we talked about in the last meeting, we're talking about screening, intervention, referral. We want to build grit within our student base. And when we look at BAR and when we look at Project Aware, we just had great presentations from Ms. Osman and Dr. Corso. And BAR is complementary to the work that Prosper does and the work that Kindness Matters and Stand for Kind work. BAR is just a quick overview of BAR. BAR is a 3-year program that is implemented through time. It's time-based implementation. They have I time and they have T time. And these two times provide curriculum within the school setting. And so BAR doesn't have a tail. At the end of the 3 years, it's a sustainable program. They do offer several training options after that. What we wanted to bring today, as we're talking about BAR, we're talking about Project Aware, we wanted to provide a cost estimate of what this would look like in the state of Wyoming. If we go to, and also with me, I do want to identify that Miss Wanda Maloney is here with me and is going to present as we move through the presentation as well. If we could go to our first slide. And Mr. Chair, with your permission, are you all right if we press through the slide deck that covers Aware and BAR?
That would be awesome. And Miss Maloney, anytime you want to jump in, you're behind our heads here, so I can't see when you raise your hand. Just go ahead and jump in whenever you feel like you want to jump in. Go ahead, Dustin.
Thank you, Mr. Chair. So as we heard before, the community project manager we have centered in Wyoming Project Aware. This is a position that coordinates all district level efforts. And what we've done with this position is we've required a bachelor's level in education or healthcare. And we have a mix of both. We have some districts that have utilized a healthcare provider, and we have some districts that utilize an education-based individual. They direct all of the mental wellness efforts within that school district. They also communicate with the district leadership team, advance district level initiatives, and administer the Project Aware Mental Health Survey. The mental health survey is where we get a lot of our data, and we execute that every other year within our Aware districts. When we're looking at that community project manager, it's just as Ms. Osmond said in her review of Project Aware. They serve as the linchpin of that engine. They understand how the engine works. They understand the intricacies of that engine and help move the vehicle forward for the school district. We also have a paraprofessional, and that paraprofessional is actually the boots on the ground. That paraprofessional helps get our students from the classroom to their telehealth services. They also do Medicaid enrollment. They'll do food pantry assistance if that's needed for that individual student / family. They'll work with all those kind of wraparound services. Now, the behavioral health provider contract, what we've done is we believe that external partnerships, the school district shouldn't be responsible for every aspect of mental health care. This kind of goes back to our our identification and screening, stabilization or intervention, and then referral. We believe that having access to a behavioral health provider through contract support, we can provide those services that fall in that tier 3 crisis, near crisis. And so with that, we've identified that provider contract within the education system should provide services 50 weeks per year. And overall, their caseload for that provider is somewhere between 32 and 35 students at any given time. Oh, go ahead, sir.
Go ahead, Mr. Chair.
So you're saying that contract would be providing services to the students year round?
Correct, sir. Yes, sir. Yeah, and when we look at that, equates to 120 to 150 students seen per year within the district, and that gets us to our modeling of 3 to 5% of student needs. Now, when we scale that, because this is a pilot to bring the anticipation is having the pilot provide one provider team, it only scales so far in a large district because that prevalence rate being 3 to 5%. If you have, say, 10 to 12,000 students in a district, that 3 to 5% is going to exceed the 120 to 150 students per year. So recognize that Project Aware isn't going to meet all of the needs in the state, but it is one tool that we have a good amount of data on for functional social connectedness and student-based outcomes. Now, also with our Project Aware model, we've placed in funding for the PBIS and MTSS system of $100,000 per school district. This would give the district options on how to do professional development, how to work within the PBIS and MTSS to provide broad spectrum support to the student population. So this is really, we're talking about that tier 1, tier 2 interventions.
Mr. Chairman.
So you educators, like our Department of Health guys, love acronyms and have all these systems. So sometimes I have to get my head around it. Could you just help me understand what those systems are? Are these computer systems? I mean, software systems? What, when you say they're systems, what is it that those systems do?
Yes, Mr. Chairman. These systems, so to break down the acronyms, PBIS is Positive Behavioral Intervention Systems, and MTSS is Multi-Tiered Systems of Support. So these look differently based on the district and the opportunity to implement and execute for the districts. For some, those are going to be information technology based with systems that monitor grade progression and try to outline or coincide grades with behavioral outputs, and kind of create this whole person concept for the student. Others can be something as simple as suicide prevention training for the entire student population. So it can look different based on the efforts and the experience and the expansion within that individual district. Does that answer the question, sir?
Go ahead.
It does. I don't understand it, but you did answer it. I'm just,
Apologies.
well, no, I'm just trying to visualize how that's, walk into a district and there's this system in how that works, and we can have that conversation.
Absolutely.
Dustin offline to help me better understand how that would work. It sounds like
Yes,
this
sir.
flexibility, and it sounds like a key component of that, and you could help me with that, is that it connects the individual, the school, and the family.
Absolutely. That would be the key takeaway, sir.
Thank you.
We'll call that an education tutorial for you, Mr. Chairman.
Thank you.
Go ahead.
So when we look at scaling Aware across the state of Wyoming, we have a total annual cost of $12,240,000. That would provide the Aware pilot model in every district across Wyoming. Again, going back to our key points, it would provide that paraprofessional, it would provide that community project manager, and it would provide that PBIS MTSS funding for every district. And the anticipation would be being able to see up to 150 students per year in each district.
Mr. Chairman.
And thank you, Mr. Chairman. Dustin, I'm assuming, and I know that you're going to get to the department costs that are important as well.
Yes.
But these full costs would be outside the funding block, and so they'd be specific to this and couldn't be used for anything else.
Yes, Mr. Chair, Co-Chair, that would be accurate. This the thought construct of this is for it to fall outside of the model and be kind of a standalone support.
Thank you.
Very good.
So when we look at state resources, if we needed to scale Wyoming, the department believes we could do this with 2 consultants at the ETEP 10 level. We have a cost estimate of $210,000, which would pay total salary and fringe benefits for those 2 positions. The way we've designed this project is we would break the state into 2 quadrants. We'd have a northeast and northwest, and we'd have a southeast and southwest. And those 2 divisions would be the work and the areas of responsibility for those 2 education consultants. Oh, yes,
Mr. Chairman.
Just want to make sure that I'm interpreting this right. These consultants are consultants to the district, but they're an FTE to the department.
That's accurate, sir.
Thank you.
Very good.
Yeah, and so they would oversee the state level technical assistance and professional development contracts. They would oversee the external evaluation contract, which we'll get into momentarily. And then they would also manage an uninsured payment request process, which we also delve into as we progress through this memo.
Go ahead, Mr. Chairman.
So I look at that, the price there, was that structured on our typical FTE model where you have the salary and the benefits included?
Yes,
Okay.
Mr. Chair, Mr. Co-Chair, that's accurate.
Okay, thank you.
Very good.
So right now we leverage a member of the behavioral health division for the Aware grants to provide guidance and support as needed. This memo would have the same opportunity for a WDH consultant. We found that consultant with the Department of Health to be invaluable with navigating connecting us to various providers within the community. The idea behind this is to partner with the WD with this individual for processes and strategic initiatives.
Mr. Chairman, go ahead.
Thank you, Dustin and Director Johansson. Would that be in healthcare financing? Where would that be?
Director.
Mr. Chairman, there's a couple areas it could be. My mind goes to behavioral health, as Mr. Brown mentioned.
Okay, and I didn't hear that. I apologize. Thank you.
So then we press into the external evaluation support. What we've designed with the external evaluation support is to continue measuring functional and social connectedness. measuring functioning and social connectedness as we progress through this will give actionable data that the legislature can utilize to determine the warrant, the need for these services and the effectiveness of this program as we move forward. What we would do specifically with this evaluation support contract is they would oversee the NOMS, which is National Outcome Measures. That is the functional data and the social connectedness data that I referenced. They would also work and present the data on a district and state level dashboards where we'd have that readily available for our districts to make evidence-based decisions with that data that they have readily available for their districts.
Go ahead, Rick. I apologize. It's just the appropriation side coming out in me. And so why are you using an external support instead of having it within the department?
Yeah, Mr. Chair, Mr. Co-Chair, that's how we've structured Wyoming Project Aware in and of itself. So we just maintain that because we know we have a good working process with how we collect that data now. So we were just kind of, our thought process was to extend that process and continue it, as opposed to try to internalize that.
Is there a cost savings if we internalize it?
Yes, I believe we could do 1 or 2 individuals. And if we were to do 1 or 2 individuals, internalizing that, it would save about $150,000.
So could you just, Mr. Chairman, could I just ask you to maybe, as you guys go back, and I know we've got time and room, but if there's a downside to that, help us understand it.
Absolutely.
Other than we're comfortable with where we're at.
Yeah.
But if we could do that at a cost savings by internalizing it, it makes selling this whole thing with additional FTEs a little easier from that approach. So it's just, if you just look at that maybe and if there's flaws in it, I understand, but I just throw that out as a question, please.
Yes, Mr. Chair, Mr. Co-Chair, I think the only potential thing we could run into is the workforce in and of itself, trying to internalize that with the statistician type background that we would need to fill that position. It could be a hard to fill position. We know if we contract it, we navigate some of that hardship, but we can definitely provide 2 options there to help on the appropriation side. Thank you. So we also allocated $10,000 for travel as part of the model. The reality is sometimes you do need to go to the districts and help them implement or work through a very specific niche problem that they're working through at the district level. So those funds provide that travel for those consultants. IT and phones is kind of straightforward. That's the cost to maintain IT equipment, software, computer systems, web-based applications that they would utilize through their service. We also would enter in a technical assistance contract. This ensures standardization of effort. We don't necessarily need a full FTE for technical assistance. This could be accompanied with travel through an external technical assistance piece. So we program that in here as well. Oh, yes.
Mr. Chair.
And so if we even done that with the inside ETS, you would still get that charge. I think that's just important for the committee to understand that there's an enterprise model. So we go external or internal through the state agency, you're still going to have to anticipate that cost. Is that not correct?
That's absolutely correct, sir. We also had to budget in professional development and training, things like youth mental health first aid, other evidence-based trainings, QPR, some of those trainings that are there, we have to provide a strong workforce. And in providing that strong workforce, we can provide that training to those individuals. And in turn, we create long-term accessibility because the trainer can then train youth mental health first aid at the district. And that's kind of the effective model that we've been doing right now is we've got 3 individuals in the state at the Department of Education that can train youth mental health first aid, can train ACEs training, some of the other trainings that we have. Right now, we're doing the same with neurosequential modeling as well. That's a little bit beyond my intelligence level for neurosequential modeling, so I can't speak heavily to that. But it is something we're working towards. Now this next part is really important. We wanted to consider funding uninsured and underinsured students. As our last presentation said, there's health plans. Our contract partner works through the insurance system for that sustainability. When we fund uninsured and underinsured students, we took an average of 9% uninsured as to what we would be covering based off a prevalence rate of 3 to 5%. And we modeled $300,000 would be a pot of money that could help support high deductible health plans and uninsured students receive this care directly, because the fiscal modeling doesn't support providing services to uninsured and underinsured students.
Mr. Chairman. So I think if I understand this correctly, Dustin, so there's a difference between uninsured and underinsured. So a co-payment would be to an underinsured. An uninsured, unless you're saying that you're going to pay a percentage and then the uninsured family is going to make up the difference. There's not a copay for an uninsured. Am I seeing that wrong?
I guess let me clarify what this looks like. So if for example, my son's on a health plan that has a $1,500 deductible before benefits start kicking in, we know for functional purposes for many families that's unaffordable. The idea would be is that family could utilize these funds in order to receive healthcare for the student. And kind of bypass that insurance process.
So, Mr. Chairman, help me understand that. So are you saying that if the whomever the state dollars goes to pay for that care, then the family is able to take that amount contributed and apply it to their deductible? I'm not sure that's possible.
I don't know if that's entirely possible, but that was the idea, was that we would bypass that process and pay directly from the state.
And so I get that kind of that concept. I think it's got some wrinkles in it, but I understand that from the underinsured.
Yes.
But the uninsured is a different topic altogether.
Yes.
Because you're just saying that we would pay for their cost of treatment, and then so as you visualize that would be up to, is there a cap on that? How does that look?
Yes. So Mr. Chair, Mr. Co-Chair, what that looks like is we've designed Wyoming Medicaid as the guardrail for implementation of something like this. We would take the provider taxonomy, and based on the provider taxonomy, the reimbursement that's authorized. So for example, if a mid-level provider receives 70% of the Wyoming Medicaid rate, that is what we would pay for that uninsured student. So we tie it to the guardrails because there's a safety factor. There's a support structure and a guardrail that we can measure.
Would there then be an expectation that if the family was uninsured, qualified for Medicaid, but had not enrolled as Medicaid, that would be a condition, that there would be that evaluation of Medicaid eligibility, and if they were eligible to get them enrolled?
Yes, Mr. Chair.
Okay. Thank you.
You're welcome. Now, the annual state total costs is $1,043,400. The combined total Project Aware cost, combining the Project Aware in and of itself, and then the annual state cost, is $13,283,400 annually. I'll pause there if anyone has anything before I move into bar.
So I think, Mr. Chairman,
Go ahead.
I think our recommendation last year to address K-12, of course, we put 10 million in for grants to get counseling and that sort of thing in the system, but we had you'll recall last year we had a suggestion that we put 125 million into the system, and I think that through this effort and further defining what the role of the district is and looking at what's been successful, a reduction of $110 million isn't bad.
Mr. Chairman.
Go ahead, Rick.
Before we move on, Dustin, I appreciate that overview. I just want to be clear because I get confused easily. So in terms of kind of the coverages that you were mentioning through Medicaid and CHIP with kids and adolescents, we basically have 0% poverty level to 200% poverty level covered through those programs. So the idea is not that this would bypass that, but the requirement would be to get those kids signed up for that insurance. Maybe there's a stopgap measure there, but could you re-explain that to me? I just want to make sure we're leveraging what we have with, you know, our Medicaid state plan and our Kid Care CHIP program, which is also administered by our Medicaid office.
Yeah, Dustin.
Yes. Mr. Chair, Director, you're absolutely correct. There would be no desire to bypass the Medicaid system. We would use that paraprofessional to provide that Medicaid enrollment and work through that Medicaid enrollment process, and work within those bounds of enrollment. I really think the uninsured cost is those individuals that are beyond that 200% poverty level, but don't make quite enough to have a traditional health plan that doesn't have the high deductible. I think it's really, there's a gap that we see right where an individual doesn't qualify for Medicaid, but they don't quite make enough as a family unit for a traditional health insurance plan. So I think that's really what we're covering with that pot of money.
Mr. Chairman, quick follow-up, and Dustin, we might want to just make sure we're visiting offline because once you get above 100% of the poverty level, you know, maybe there's not qualification on the Medicaid side. So let's take like kind of 200% and above. They're still pretty generous on the marketplace, you know, subsidies and cost sharing reductions for those health plans that really make cost sharing pretty de minimis. So I just want to make sure for long-term financing of this thing that it would, I think, behoove us to make sure that we're leveraging what's available, both from the Department of Health and Medicaid, and also through what's available now through private insurance, where those, you know, high deductible plans through the cost sharing reduction subsidies aren't really, you know, as high deductible as they appear on paper. So let's just make sure and I know your team has visited with mine, but make sure we're connected on that.
Yeah, absolutely, Director.
Mr. Chairman.
So I think Mr. Chairman, from my perspective, that the most challenging part of AWARE, and I think that the program just really has strong value and I support it, but it's getting those contracts to provide services in Farson, or, you know, I always use Farson, or, you know, some of these rural communities. And so as we reach out, and as we heard last time, and we were in Cheyenne, that it's going to be kind of all hands on deck between community mental health providers and private providers. So then how does this go? How do you envision this going out? Does the individual districts put this out for an RFP to solicit services, or is it the Department of Education? How is that determined?
Yes, Mr. Chair, Mr. Co-Chair. I envision this as a local process. The local school district partnering with through an RFP process, determining their partnership through that process. As you stated, there are going to be some communities that don't have a local partner that will be able to apply because they, you know, may not have capacity, they may not have appropriate skill set, various variables that could get in the way of supporting that locally. In which case, we have some larger organizations in the state that are based in Casper or based in Cheyenne that would be potentially good partners for them through a telehealth construct, as well as utilizing potentially some of the funding mechanism to support when telehealth is ineffective, because we know telehealth isn't one size fit all. There are some individuals that don't respond to telehealth and need those in-person services. So we could work those on a case-by-case basis as needed.
Mr. Chair.
So, Mr. Chairman, thank you. If I could maybe ask Director Johansson a little bit now then, because we see this behavioral health redesign, and we've got Mr. Dana here, Mr. Kauser is here, so then how does this fall into the redesign and using the community mental health providers to help providing some of those services, does that fit into the redesign? Or would this be another opportunity or requirement, however we would want to label that, for our community mental health providers to participate? Because I believe we noted that the K-12 referrals are a priority population. So you would, in my mind, you could argue that that's covered in the behavioral health redesign funding model. But could you clarify any fog in that area for us?
Happy to, Mr. Chairman, Mr. Co-Chair. I think it all comes down to, the types of children that are being referred. So the general answer to your question is yes. Our high needs adolescent population and their families are statutorily defined as priority populations under the redesign. So in general, when we talk about this screening, intervention, and referral mechanism that we've been discussing in this task force for Department of Education and the school districts, I see our behavioral health centers, our community mental health centers, being a big part of that hub of the referrals when the services that are provided in the schools are not adequate to meet the clinical needs of the child. So absolutely, the point of the redesign that's taking effect on July 1st of this year will be to make our community mental health centers, as those partners in the communities, be that hub for those folks that pass thresholds that I think on kind of the general population, some of the broader efforts that we've been talking about in the K through 12 system target. This would be more at that higher level of need. When you think of intensive therapy services, medication, et cetera, would absolutely the goal is to leverage our community mental health resources. But just to caveat that, because I think it is important, we've talked a lot today and had our good district superintendent from this area here talking about what referral patterns look like. And you asked the question, okay, who's dumping kids or who's referring kids? Sorry to use kind of a pejorative term there, but if it becomes everybody, every single child in a K through 12 system that is flagged for some sort of mental health need and gets referred to a community mental health center, that prioritization will have to happen. So the intent is really behind, with our acute psychiatric adults, our criminal justice involved adults, and our high needs kids, to try to target and address the most serious or the most in need first. The second thing I'll mention, and would certainly welcome any comments from our providers, is again, going back to this sort of supply and demand, we don't want to inadvertently create wait lists like we have now. So there has to be some sort of filtering mechanism of what the state dollars in the behavioral health redesign go to. But I think one of the benefits of the behavioral health redesign is we're lessening the micromanagement on the rest of the service business. So you will have community mental health centers outside of behavioral health redesign populations that have service lines that they can provide for, insured individuals, non-priority populations. And that all comes down to capacity and the economics of the specific center. But there's nothing that would govern a mental health center being a partner with a district in and outside of the behavioral health redesign kind of contracts and systems that we've developed.
Mr. Chairman, and so I guess I was thinking, thank you, because that helps, but I'm also thinking then, particularly as we look at the remote areas within the state, the remote areas within a district that a community mental health provider serves, but doesn't have an office, or that then if they have the capacity to then travel or provide teleservice or do some sort of service to these remote schools in the district, might be, it fits into this conversation, does it not?
Mr. Chairman, Mr. Co-Chair, yes, it does.
And so then, as you look at that number that Mr. Brown has here, I think that would, for these services, I think that may be fair to say, okay, that kind of gets us started. But I think that this is the most complicated component of implementing this K-12 model, is to make sure that we have the services available to all the schools in the state. And it's certainly much easier, if you in a larger area than if you're in a smaller area and dependent on that. And so I think if we can get that figured out, the rest of it, so that's my angst, and I think we're on the right track, but is it fair to say that we don't, that number's not chiseled in stone and the process is not chiseled in stone?
Director.
Mr. Chairman, Mr. Co-Chair, I think the process is getting chiseled in stone. It's going to be a little bit of a evolution over this first year of implementing the redesign. Absolutely. So I want to be clear that I think we have good process for referrals, for handoffs, et cetera, worked out with our providers. Now, when it comes to other stakeholders in the communities, and this is as true for schools as it is for courts, as it is for law enforcement, there's a lot of entities that touch these populations that will evolve over time. And what I'm pleased with is the partnership we do have with our providers to work on that, to have dollars that are out there so that they can market to their communities what's available, that we can be clear on the department's expectations for those providers in this first year. But to answer your question directly, I don't think it all depends on what enrollment and client volume looks like in BHR. So we have a few behavioral health redesign. So we have a few unknowns that I think in the first quarter, starting on July 1st, we'll learn a lot about that patient volume, both on the adult side and the adolescent side, to see what our centers, what our providers see in terms of enrollment. Those are questions I can't answer that aren't chiseled in stone yet. And I think those enrollment numbers and that capacity issue will dictate a lot of what's available at the community mental health level for the K through 12 system. But the concept, the policy that the legislature set, I think is the North Star guidance here, that there is an intent that with our high needs kids, that the community mental health centers, the behavioral health centers will be a network of available providers in some capacity statewide. That variation is absolutely there of what scale is available in a community like this versus a community like Casper. It is just remarkably different, and we need to be cognizant of that.
Mr. Chairman. And those who are less acute and may not be considered priority population would still have an option to be served by a community mental health center, but it would just be outside the behavioral health redesign component, and in that income or obligation to the provider is kind of what we're talking here and providing, and falls outside those state general funds.
Director.
Mr. Chairman, Mr. Co-Chair, yes, I would absolutely agree with that. And I think relevant to this K through 12 conversation, when we talk about eligibility and what funding sources is used, not to sound braggadocious about our effort, but I'm pleased with some of the things that we've worked out where for this population, you're absolutely right. I think in and outside of the behavioral health redesign, there's opportunity there for service provision. In addition, the reason for my questions for Mr. Brown about Medicaid and CHIP is a good chunk of this population that we're talking about that might not be high acute yet or high needs will very likely fall into this family income of 0 to 200% of the poverty level, which then brings with it a coverage source through Medicaid or CHIP. Now that can reimburse and pay for services at community mental health centers. They're all Medicaid enrolled providers, but it also opens up options for the district and the family on any basically enrolled provider that could provide those services. So I think, just as I mentioned before, making sure that we're leveraging coverage sources, whether it's state general funds through our mental health centers, Medicaid and CHIP, or generous subsidies on the federal side for private insurance products, that opens up access, or at least a pay source. And I want to be careful and not say access is just guaranteed because you have Medicaid or private insurance. There's dynamics that go to that, and size of the community is a big part of that. But it at least opens up a pay source, and that demand in theory over time would likely encourage supply and providers that could benefit from that pay source.
Follow up, Mr. Chairman.
Follow up, go ahead.
So, Mr. Brown, I guess the other maybe not red flag, yellow flag that I have as we work towards implementing that is the potential of creating a silo where we have resources available, but we have a district that say, no, we're going to use these services and we're not. I think that there's a potential of creating these silos that we're trying to eliminate between Department of Health, Department of Education, Department of Family Services. Does that responsibility on determining what resources are available, does that come back on that coordinator position? Is that where we
Yes,
provide Lloyd with his Valium?
Yeah, Mr. Chair, Mr. Co-Chair, when we're looking at that community project manager is the relay to the district's decision-making force. So I think that decision relies with the district in and of itself, not necessarily that community project manager. We would want that to be a district level decision. I do think there is the potential for silos, as you said. A district could get comfortable sending to a certain source, whether that's their contracted referral partner, whether that's the community mental health center. I think there's just a piece where individuals go with what's known and what they're familiar with and what they're used to. But through collaborative efforts, I see it as building blocks. We start with project where we look at partnering with community mental health centers to create these pathways in our referral process. And I think the big thing that we're kind of talking about is access to care in and of itself. And that takes multiple pathways to get there. Silos are detrimental to that process, but they can happen.
And finally, Mr. Chairman. Go ahead. And I want to make sure that whoever's watching on this, that I'm not implying that all of the services need be provided through our community mental health programs, because we've had some providers step up and are providing services. They've done a great job. I'm just trying to, as we heard at our last meeting, it's going to take probably an all-in effort. And I think that conversation between the providers in the various parts of the state are just, we need to have the flexibility to use whom we can use, correct?
Yeah, that's absolutely accurate.
Thank you. Thank you, Mr.
Very good. Go ahead, Director.
Thank you, Mr. Chairman. And I just feel a sense of kind of issuing a word of caution in this conversation because of access. And the director kind of hit on it briefly, but I wanted to reinforce the conversation. Funding is great and very important, but if there isn't the ability of a community to provide that service, the funding's not going to matter. And so as we think about funding, we're equally thinking about access, if not more, thinking about the investment in that access. And is that the best place for those dollars? And I give the example of the Wyoming Boys School, where we have not had a full capacity of therapists available to the boys' school because the local community mental health center hasn't been able to hire therapists. And so there's a funding source, there's a population. It's not an easy population, but certainly access is very easy. They're going to be there. It's no missed appointments. And still, having the ability to provide that service is tough. So I very much appreciate the model. And what I appreciate so much about the model is this idea about these external communications, these external partnerships between the schools and having that person who is that go-to for it. And this is speaking from, a system, a child and family serving system that really does and appreciates any pathway we can have and develop between a system like a school and then with the child welfare system and the juvenile justice system. So I like this idea and this model, but I do want us to also be a little bit cognizant of really the mental health shortage we have in the state.
Pretty good. On to bar. Okay. Onward to bar.
Yeah. So, Mr. Chair.
I'll go to the bar. Is that what you
Yeah.
Okay, go ahead.
So the bar system, what we've been talking about, and this segues really well into the system in and of itself. I won't go through the full details that I went through before, but the idea is through building relationships and through utilizing data for evidence-based decisions, you bring the prevalence rate down, which which in turn gives the district more capability to support and provide those interventions directly within the school district. And what we see is we see a reduction. Right now, we're measuring prevalence right around 1 in 5 students, 20%. We can see with these systems, whenever they're implemented with fidelity, you drive that down into the low teens. 10% is a realistic goal. So you can cut that prevalence rate and that need with a system like BAR in half. So Building Assets Reducing Risk, BAR, is a national school network program that delivers positive behavioral health results. It uses curriculum, it uses programming at the school level. And what we have with a cost summary for BAR is BAR costs $80,000 per year per school. So whenever we take that we have 348 schools in Wyoming, we're looking at a $27.84 million investment annually. For 3 years. Yes. A key takeaway with this BAR conversation is you build the program and then the program is self-sustaining after that, because you create a culture, you create network system level changes within the district. So it's an upfront investment, but you have long-term gains because that prevalence rate drops. The capability of the school district increases. So you're seeing gains on 2 fronts. You're seeing less student need and you're seeing more resources within the district. So you kind of come to this point where you have just this middle portion that you're trying to support from a student base.
Go ahead, Mr. Chairman. He liked that self-sustaining part being on the
I
appropriation side.
think,
Go ahead.
Mr. Chairman, that's really an important part of this conversation, because as we move forward and try to sell this to our colleagues on the appropriation side, to understand that that's a 3-year commitment is much easier to do than saying that this is an ongoing in perpetuity. And so I think that's important. So I think the light is starting to shine through the fog here a little bit for me. And so I've got a question for Dr. Corso, that it appears that this approach that BAR takes really starts to implement this idea of social behaviors, and am I catching that?
Yes, sir. Yes, Mr. Chairman, you are correct. They align very well with culture change and changing sort of systems.
Well, look at that, Mr. Chairman. The blind cell got the air coin.
Thank you.
Yes, sir.
Mr.
Yes,
Chairman.
Mr. Chairman.
Mr. Chair. Oh, I'm sorry, Dustin, go ahead.
No, go ahead, sir.
So can I ask a somewhat maybe naive or stupid question on the fiscal side? I see here on the total scaled cost, it'd be, $27 million on a biennium. Where does the self-sustaining portion come from that, if that's what it takes to do it? So it seems to me it's either in the calibration model or through appropriation. So what does self-sustaining mean there?
Yeah. So Mr. Chair, Director, when we're looking at self-sustaining, the curriculum is 35 lessons that are implemented over the school year. In total, they have 105 lessons, 35 geared for your 9th, and then I believe 11th and 12th for 35 of those lessons. I think my math's over, but the idea is 35 lessons for these 3 cohorts. And the way that it becomes sustainable is BAR brings in their personnel, a BAR coordinator, throughout the year and does 16 hours of professional development to teach you how to execute that curriculum. And they train the staff to train other staff on executing that curriculum. In and of itself, there is a tail that can be purchased that's optional if you want to continue that training. So that training falls off, but that's where the sustainability is created, is over the 3 years of building the program.
Go ahead. So the fiscal requirement would end because would do that training and implementation of the system internally without a fiscal requirement. The fiscal requirement right now is for BAR to implement that within the respective district, right?
That's accurate. Yes, sir.
And so, Mr. Chairman, Mr. Co-Chair, that makes sense. We do train the trainer model as well. It always comes down to after that initial investment, and maybe that this is a one-time investment of continuing, but then it becomes, where do you incorporate that, right? Is it if
and tea time. And those times are where you actually implement the curriculum, and the curriculum is implemented through science and social studies. So it's not, whenever I went to high school, everything was done in English. If I dates it across multiple sectors, building with teachers and educators, and then we have student to teacher relationship building through the curriculum. Statewide. We look at one education consultant because so much of this work occurs within the BAR construct and the BAR framework. We do believe that largely that implementation consultant, that education consultant that we would utilize would support district rollout. It would be there to troubleshoot and help manage with fidelity the implementation science. Manage that contract with BAR. We see BAR as a state level contract that to utilize that $100 for the annual comprehensive cost. So not by annual. If we remove the community project manager, for example, the program's effectiveness is.
Mr. Chairman,
Go ahead, Director.
if I may, just a little bit of context, as we talked a lot about the behavioral health and behavioral health redesign. Just for context, our annual budget for all community mental health and substance abuse is $50 million. And it's one of my largest line item budgets. So I know there's a big scale when you talk about all K through 12 students. There's a lot of students. So don't get me wrong. I'm not trying to get into a match with WDE of who needs more money, but just in terms of the legislature's potential intent to say we want to provide services for K through 12 students at varying levels of need, those opportunity costs are certainly there. So with what Director Schmidt mentioned about our scale and access in certain communities being less than others, it's absolutely true. And recruiting is a big part of that. Our budget for those contracts, for those services, really do dictate the amount of population we can serve.
Ms. Maloney still with us?
Ms. Maloney, have you fallen asleep or are you still here?
She may have moved over to joint education.
I am still here, so I can.
Ms. Maloney.
Good morning, Mr. Chairman and members of the task force. My name is
Do we
Wanda
want to talk
Maloney.
briefly about the stakeholder meetings that we've conducted? Sorry.
Certainly, I think my feed may be just a little bit slow.
Little technical difficulty at the moment.
Region 5 BOCES. And like we are like our school psych, we contract for a day and a half week for school psych, so we try to mitigate that, save money where possible for
Sure.
us and the state, but also like with Director, um, I'm hopeful that we can work together with all of our resources, with DFS, with High Country Counseling, because we're not great at doing that right now. So I would hope that we could do that and that could mitigate some of our issues. But like, I didn't even know, I wrote it down, but I can't remember, starting July 1st. I didn't even know that was out there because it's not really been publicly announced. So that's nice to know, but then I'm worried about them being overburdened and overtaxed and have the funding to meet all the needs of the students that might potentially be going their direction.
Thank you. Thanks for being here.
Well, thank you.
Yeah.
but also in order to get Wyoming people who are passionate about mental health into the mental health workforce sooner, as well as expanding that workforce without compromising scope, without compromising training, and being able to meet Wyoming's needs better. Through the WICHE program, we know that the state of Alaska has this very broad behavioral health pipeline for those as early as an associate's onto a doctorate program. I can't say whether or not the task force is going to take that on, but it is something that I have graciously been appointed to it. We'll be working on in July, and I'm hoping to have more answers for the task force come that August meeting on August 1st. Obviously, we all can't be in two places at once. And so if there is anything that you may need from the Wyoming Education Association, I can absolutely steal any notes from Laramie for this committee if that is something they feel like they might need. Otherwise, I stand for any questions.
Go ahead, Mr. Chairman.
Thank you. Lindsay, is your workforce group looking at the University of Utah model, the RUT, R-U-U-T-E, that it's the rural for medical and psychological education? Have you looked at that at all?
Mr. Chairman, Representative Larson, I know that that is on the agenda. We have people from the National Council that are going to come and meet with us, and I do know that Utah will be of a topic of conversation. I have not looked at it as close as the Alaska model, just because that was something that was presented earlier to the state of Wyoming in 2019, but it is definitely something that's in discussion.
And I would add to that, that's tied to WICHE as well. Go ahead.
That is tied to WICHE, and we have, I think, 5 or 6 Wyoming kids down there now and have a good relationship within Wyoming. And there's also a conversation about incorporating 5 or 6 seats in your medical school. So that,
just of note there, and WICHE, I'm glad you touched on WICHE, because that's something we are, I would precursor that with, I'm a WICHE commissioner, which I thought I was going to give up when I retired from the legislature, but apparently the governor tells me I'm not. So I will be there for an additional 3 years. But WICHE does have the psychological program, which is very strong in Alaska, which is only one of the pieces. We actually have a very strong committee, a subcommittee of WICHE, which I'm on as well, with behavioral health. And that is something that Wyoming is going to pursue, fairly low cost to no cost, which we will be dealing with in the future. And it's something maybe I'll bring back a report to this committee before my time in the legislature is up, because it's important and it's very valuable. Suicide prevention in the veteran population is a big issue that we deal with in WICHE a lot. So thank you for touching on that. That's an important note. Questions from Ms. Seminole? Seeing none, thank you very much.
Thank you, Mr. Chairman.
Others in the audience who wish to discuss or talk to us, don't be shy. I know you want to go to lunch, but.
Mr. Chairman.
Yes, go ahead.
Just a note, take this or leave this. I know Miss Davis with the governor's office is traveling today and has been communicating with LSO on the adjusted schedule. Through the magic of technology, I've also been communicating with her. And if the committee would like, I'm happy to give the overview on the governor's mental health initiatives. I'm not sure if she will be available this afternoon. I think she's heading to the airport soon and could potentially join in the afternoon, but totally up to the committee's or chair's discretion, but happy to provide an overview if you'd like.
I would love that, Director, if you could do that. Give us your view, and then if Jen wants to throw in some stuff later, we'll get it later, but if you would, that would be very valuable to us. Go ahead.
Well, thank you, Mr. Chairman. So I'll be brief, certainly not speaking for Jen, but most of these initiatives we are involved heavily in. So I know she shared a presentation with the task force. I know we're not in screen share mode. So I'll just try to describe it as best I can, really outlining the governor's strategic plan for behavioral health and behavioral health reform. There's basically 5 pillars, 4 or 5 pillars of the strategic plan, beginning with behavioral health redesign, our community mental health center reform that we've been talking about briefly today. So just to provide some of the details around that, as we've talked about, this concept came about at least 10 years ago, if not more, of what should the long-term vision for the state-funded behavioral health system be through our network of community mental health centers. And a couple of years ago, the legislature passed legislation to direct the department to engage in that reform, where essentially two things happen. Priority populations were established in statute. So acute psychiatric adults, you think Title 25 type clients in that bucket. Criminal justice involved both at the state and the local level. So Department of Corrections clients, as well as local and county detention center clients coming through the Title VII system or other criminal justice or judicial mechanisms. High needs kids and their families is the third priority population category. And last but certainly not least, a high need and low income, below 200% of the poverty level population will be prioritized for the state funds. In addition, we are changing the way that we procure and pay for those services by continuing our base payment methodology that has been referenced today, paying on a fee-for-service basis for the services that are provided to this new defined population, and then more of an innovative outcomes-based payment system, which will be tested in the first 1 to 2 years of behavioral health redesign, where we will look at whether or not it is effective to pay providers directly for generating social outcomes for their priority populations, things like housing, employment or volunteering, community engagement, treatment engagement, school attendance, et cetera, essentially measuring things like, is the client in jail or in corrections? If not, essentially a per member per month, for lack of a better term, bonus payment will be levied. We'll test that over the first year or two to determine if we can really move the needle and if those types of payments are effective to actually pay directly for the achievement of kind of socially determined outcomes, which we're excited about. The next pillar, as Ms. Semino just discussed, for the governor's strategy is on workforce development. So there is an official task force that has been set up to look at the behavioral health pipeline as it pertains to our ability in Wyoming to sustain behavioral health services. We all know that workforce, regardless of where you work in this field, state, local, private sector, nonprofit, et cetera, workforce really determines what kind of scale, what kind of capacity you have. Suicide prevention is another pillar. I'll touch on that just